Thank you, Professor Thạch Nguyễn, for introducing me to the conference like a member of SCAI. The topic we are talking about today is the intervention for acute ischemic stroke. Why we will talk this topic in the conference of cardiology? Because our patients, the patient of cardiologist, contributes about 30 to 40% of acute ischemic stroke patients. And the trend nowadays, there are more and more interventional cardiologists participate in stroke intervention. So for acute ischemic stroke, we concern today is the large vessels occlusion. This is not small vessels. When happens an acute ischemic stroke, two conditions occur simultaneously. First, the sudden occlusion of a large vessel, like in acute MI. And second one is the insufficiency of collateral circulation to the ischemic area, like this. It's the occlusion of the M1, it's M1. And the insufficiency of the collateral to the MCA area. And if no revascularization done, the brain will be infarct after 6 hours. So the time window is very narrow, very narrow. We have to do quick as possible for the patient. And here is about the contribution of our patients to acute IS. The patients with a non-valvular atrial fibrillation, the patients with mitral stenosis, with left atrial thrombosis inside, and the patients with a mechanical cardiac valve. These are three typical type of patients contributed to ischemic stroke. The first question we have to mention, what is the standard treatment for revascularization for acute IS? More than 20 years ago, it is the era of intravenous thrombolysis, which is the IV RTPA therapy. Long time after that, up to 2015, that means 2 years ago, IV RTPA is a unique choice for stroke treatment. But 2 years ago, we have a consensus of ASA and AHA about the role of mechanical thrombectomy, like the primary PCI in acute MI, for revascularized the big vessels occlusion in the cerebrovascular system. So what is mechanical thrombectomy? It's different from acute MI? Yes, it's different. Because almost the patients with acute stroke, the brain vessels is normal. We have to remove the clot out of the brain vessels with two types of devices. The first type is a stent-like, like a solitaire FR from Medtronic, the Trevor from Stryker, and the second type of mechanical thrombectomy is aspiration tube, especially like the ADAPT system from Penumbra and the ARC from Medtronic. And what is the latest guidelines for acute IS at the moment? There are 3 points, important points. The first one is that the role of IV ITPA is still efficacious. The second one is that the role of endovascular thrombectomy, which is the indication of 1A. Patients should receive endovascular therapy with a stent retriever if they meet all the criteria. It is a quite new recommendation. And the third one is very, very new recommendation. We don't wait and see the efficacy of IV RTPA. Observing patients after intravenous RTPA to assess for clinical response before pursuing endovascular therapy is not required to have beneficial outcome, and it is not recommended. Now, what are challenges and how to overcome when we have to intervene the stroke patients. There are at least 4 challenges in our experience and in the literature. First, it is a teamwork organization. The second one is the time saving. The third one is a thrombus understanding. And the fourth one is the technical difficulties we have to overcome. Now, teamwork. Teamwork, why is it so important? And the further thing we have to do when we have implementation of stroke unit, stroke center. It's a different from the acute MI. One cardiologist with a 2 technicians we can do quickly for acute MI. But for acute IS, we have to have at least 4 to 5 doctors. First, at the door of the hospital is the emergencist. Second is the neurologist, the radiologist, interventionist, and neurosurgeons. The teamwork must be ready 24 hours a day and 7 days a week, including holidays. And the teamwork is very important in one hospital. And we must have teamwork among hospitals to receive the patients transferred from the other hospital to our hospital. It's not easy. So the one because in our experience, I don't know how about in China, to have a good team is not easy in many hospitals who begin to do the stroke intervention. The second one is the time. Time is the brain. It is a slogan of neurology. Within the 6 hours from onset, we have to do as soon as possible. The earlier, the better. During 6 hours, we have to save every minute for the patient because the time loss is the brain loss. We should avoid everything unnecessary like this. Here's the workflow for management of the acute ischemic stroke. For the onset, we have to transport the patient to the hospital, and this is a T1. It depends on many things from the patient's family and the society. And from the door to the imaging, we usually use the CT and CTA. We should do during 20 to 30 minutes, and maximum 60 minutes from at the door of the hospital. We have to give the patient the definitive treatment like IV RTPA if indicated, or mechanical thrombectomy. That means from the onset, during 6 hours from onset, we have to have the decision of treatment and start treatment, and the total time for revascularization must be shorter. We continue with the third challenge is the thrombus, because the thrombus is quite important and quite difficult in acute ischemic stroke. It's different from the acute MI. Acute MI stroke, thrombus is not so much, but in acute ischemic stroke, not all thrombus is not fresh and soft, not all at the same size, and not all in one side. It may be in the 2 sides in tandem lesions, it's a cervical segment or intracranial segment, both sides bilateral ICA or posterior and anterior circulation. In one word, we can say it's not easy. It's not always easy to remove out of the brain. And the last one is the technical difficulties. For 2 types of removal techniques, the most of patients is frequently favorable. But there are sometimes, at least 7 types of difficulties we will meet during the intervention. First one is the carotid artery stenosis. It's quite frequent in the cardiovascular patients. Here's the image. It's like in the QMI. If the thrombus is located here, we have to put a stent to open with the distal protection. It composed of 60 to 80% of AIS cases. So the carotid stenting must be always available in the cath lab to cure. If the clot migrates to the intracranial segment, we have to remove with the solitary stent or penumbra system for aspirated. Second one is the cervical carotid artery dissection. The thrombi always fill up the cervical ICA. We have to remove with the ADAPT system. Then carotid stenting. It composed of 2 to 3% of cases. Here's the image of the right ICA, the normal, with the collateral to the left ICA. And there's the occlusion of the left ICA at the cervical segment. We have to remove with a clot inside here with the adapt system. And then we put a stent through the segment, the petrol segment up to the origin segment of the ICA, and revascularize all the territorial cervical and intracranial cervical of the system. The third one is a traumatic intracranial carotid dissection. It's rare, but it should be wanted for the neurosurgeon with the patients with the trauma, the head trauma, and no hemorrhage in the brain city, but the symptom like a stroke. We have to do the CTA quickly, and we will reveal maybe the dissection at the terminal ICA here, and it called a stroke. Here's the DSA from the right ICA with a collateral through the narrow lumen, and the collateral is not sufficient. And the left ICA occluded at the terminal segment, and we have to make a PTA, and after that, the unique choice is intracranial stenting with the wingspan in emergency to revascularize the truth lumen. And false carotid aneurysm is another difficulties due to the traumatics. We have here the false aneurysm, and here's the origin of the thrombus formation. It will migrate into the intracranial segment, and in such a case, surgery is difficult, and the cover stenting is the best choice. We can sacrifice the false aneurysm. 5, aortic dissection type A. One of the complications is stroke. So the CT we have to do for patients with stroke from the aortic arch up to the head. And here we reveal the occlusion of the ICA, and we have to put stent to open the true lumen because it is collapsed by the false lumen from the aortic arch. So for these cases, we have to do CTA, must cover all the aortic arch. The carotid stenting indicated at first and followed by the aortic arch replacement, so that we can cure the patient. It's a very serious conditions. For the patients with a PAD, the CTO of bilateral iliac artery or the CTO of the terminal abdominal aorta is one of the very difficult for stroke intervention. We have no femoral entry, both sides. For this case, the cardiologist very easy to do the abrasion route to navigate the catheter up to the subclavian to the common carotid artery. And here we can do the angiography to reveal the occlusion of the ICA origin and the MCA origin. And through that, we put the long sheet to the CCA, and we use the solitary stent of the aspiration system to remove the clot through in the segment of the MACA intracranial, open totally ICA and MCA occlusion. It is infrequent. About 2 cases, we have 2 cases among 350 cases in our center. The groin pulsation must be checked for all stroke patients. We have checked the bilateral femoral pulses, and the abrasion actually assessed must be skilled. The last one is a difficulty in the aortic arch type 3. We have to use the coaxial system, 3 to 4 catheter, a long sheet, long and stiff hydrophilic wire to overcome the type 3 aortic arch. And the techniques for 4 vessels, cerebral vascular angiography techniques, must be very skilled, so we can get over the aortic arch to go up to the cranial base. Summary: one was 40 challenges in stroke intervention, at least. The first one is the teamwork in hospital and among hospital, because it is the power of union. The second one is the time saving, because the time is the brain. The time loss is brain loss. The thrombus is always the enemy, the big enemy. We have to overcome. We have to remove it out from the brain artery. And last, the technique is a weapon of interventional radiologist or interventional cardiologist to open all of the territory of the brain vessels. Thank you very much for your attention.